Hi, this is Dr. Bhargava. Here is the next video in the series Abdominal Imaging Case Review. This is our first patient. They were suspected of having an abscess in the prostate, and a CT scan of the abdomen and pelvis was performed. And so here's the prostate, and we see that inside the prostate there is a low attenuation focus with thick peripheral enhancement. And this is the coronal image shows urinary bladder sitting on top of it. That's the prostatic abscess. And here's the sagittal image showing the bladder and the abscess inside the prostate. This is our next patient, and there are two images here. They underwent a CT of the abdomen and pelvis. The finding was picked up incidentally, and if you look at the axial image in the soft tissue windows, you will find that there is a prosthesis in the right hip, but because of all the artifacts, we are not able to see the prosthesis very clearly. But when we looked at it on the coronal images using bone windows, which is appropriate for anything that is very hyperdense, we find that the left hip prosthesis is fine, but on the right side there is an abnormality. The femoral head has dislocated out of the acetabular pocket. So this patient has a dislocated hip prosthesis. Here is another, the scout image, which I frequently go to whenever there is something hyperdense on the axial or cross-sectional images. So again, the left hip is normal and the right hip shows dislocation. This is our next patient, and we are looking at two T2 weighted images from their MRI of the pelvis, and the finding is very characteristic. We see one uterus here and another uterus here, and on the coronal image we find that they are connected with a single cervix, and here is one horn, here is the other horn. So this patient has a Mullerian duct anomaly, which is a bicornuate uterus with single cervix. This is a graphic showing what are the possibilities or the different kinds of Mullerian duct anomalies. Here on the top left is the appearance of the normal uterus. Then we have a unicornuate uterus with a banana shaped appearance, uterus didelphys, where there are two cervix. Bicornuate uterus, the patient that we saw on the previous slide with a single cervix. Septated uterus, where we see a septum going down. Arcuate uterus, where this projection is prominent. And DES, drug-related effect, which is very rare but may be seen, and it could be a board's question. Here's our next patient. They presented with abdominal pain, and a CT scan of the abdomen and pelvis was performed. And I'm showing you some images, one axial, then coronal, and the sagittal image. Clearly, they have a pneumoperitoneum, and whenever there is pneumoperitoneum, we are looking for ruptured viscus or bowel. Frequently, what I have found is if you trace the free air from outside to inside, it will lead you to the pathology. And so as we trace it here, it's taking us to the stomach right there. Similarly, there's a problem or abnormality right here, and you can go to that level tracing this fluid around, air around the liver. And similarly, there was an abnormality seen on the sagittal image as well. So this turned out to be a perforated gastric ulcer. This is our next patient, and they were diagnosed with prostate cancer. We are looking at their CT of the abdomen and pelvis, and we find that here is the urinary bladder, and towards the posterior aspect of it, where we have the UVJs, there is a mass that is protruding. That's their primary prostate cancer involving the urinary bladder at the side of the UVJ, and we see hydroureter on the left and also on the right sides. We see the same finding here as well. And here's the sagittal image showing the tumor extending from the prostate to involve the urinary bladder. And they also have sclerotic bone metastases involving the sacrum. On the next slide, we have two images from their whole body bone scan showing osteoblastic bone metastases involving the sacrum and the right ilium. Probably a focus in the left rib as well. This is our next patient, and on their single frontal view of the chest, we find that there is opacification of the right hemithorax. And just from this opacification, we cannot tell what's causing it. Most of the times, there is a large pleural effusion that looks like this. That's the most common finding. But there can be rare findings, and if you have a correlation with the CT, that will tell you what's happening. So here in this patient, we found that they had a large mass which has a thick wall and central necrosis involving most of the right hemithorax, and this mass turned out to be a lymphoma. This is our next patient, and they underwent a CT of the abdomen and pelvis. And right away we can tell that there is an abnormality in the colon involving the right side, also seen right here involving the left side, and also extending from the sigmoid to the rectum. The findings are that there is mural thickening, the wall is thick, there is mucosal hyperenhancement, and there is surrounding fat stranding and reactive free fluid. So this patient has pancolitis because it involves the entire colon, and whenever colonic inflammation is seen, we want to describe which segment of the colon is involved with those findings. And same thing for small bowel as well. So this patient has pancolitis and reactive ascites. Here is our next patient, and there are two sets of images. The images on the left are T1 weighted post-contrast axial and coronal images showing a filling defect in a hepatic vein draining into the IVC right there. And the coronal image shows the finding in another view where a tumor has grown into the hepatic vein and is going towards the IVC. And one tumor that has the propensity for doing that is hepatocellular carcinoma. And so whenever you are evaluating a CT scan or the MRI of the abdomen in a patient with HCC, make sure you identify the borders of the tumor correctly, especially where it abuts a branch of the bile duct, portal vein, or the hepatic vein, because this tumor is notorious for growing into or invading the surrounding structures. And so we see the same finding here. Main portal vein is involved on the CT scan post-contrast in another patient, and we see that finding here as well, that the tumor is growing into the main portal vein. This is our next patient, and we are looking at two different CT scans, the sagittal views in the bone windows, and on the prior study we find that they've had a compression fracture here involving L1 vertebral body, and on the current study that fracture is seen here, but there are new compression deformities in L2 and L3 vertebral bodies. So make sure when patients come in for abdominal pain, you look at their vertebral body alignment in a sagittal projection using bone windows and compare it to the prior study. This is our next patient, and they presented with abdominal pain, and previously they had an abscess which was drained by a percutaneous catheter, and the abscess resolved, the catheter was removed, but they presented a few weeks later with abdominal pain, and a CT scan was performed with oral contrast, which shows that there is fat stranding in the mesentery, and then that fat stranding and foci of air and some enhancement extend through the abdominal wall musculature into the subcutaneous space. So they developed an enterocutaneous fistula at the site where a catheter was previously placed. That is a common complication when a catheter is placed, so it's very important to look back on the prior studies to figure out what was done in this region and what could have developed into something like this. The importance of oral contrast is that when there is an enterocutaneous fistula, you're looking for any contrast extravasation into the intraperitoneal compartment, and if there is any, then this patient definitely needs surgery. Here is our next patient, and if you were just looking at their CT scan of the abdomen and pelvis in axial projection, you would comment on the Foley catheter in the urinary bladder and move on. But what I want to tell you is whenever there is a Foley catheter, always look at it in the sagittal projection, right? This bulb of the Foley catheter isn't in the urinary bladder. It has been inflated in the prostatic urethra, and instead of draining the urine, it's actually causing obstruction of urinary drainage, and predispose this patient to not just pain because of insufflation of the bulb in the prostatic urethra, but also predisposing them to superimposed infection, which I believe they have because there is a focus of air in the non-dependent portion and the wall appears to be thickened. And so whenever there is a Foley catheter on a CT scan, make sure you look at it on the sagittal image, especially in male patients. In females, it's unlikely because they have a shorter urethra and most of the times the bulb is going to be in the urinary bladder. But in males, it's possible that it has been malpositioned and you want to report it to them as soon as possible, get it removed and another one put in. Here on the coronal image, we also find signs of hydronephrosis secondary to this obstruction or obstructive catheter. This next patient had a CT of the chest with contrast to evaluate a suspected tumor, and when we see fat attenuation filling defect inside the left atrium, and it's seen on multiple projections here, this turned out to be a left atrial myxoma, which is the most common primary cardiac tumor, and it arises from the wall of the left atrium. Here's our next patient, and they had a CT of the abdomen and pelvis. Here we have a fat attenuation tumor in the left side of the pelvis with eccentric focal calcifications, also seen right here and here in a female patient. This is most definitely a mature cystic teratoma or dermoid cyst. Here's our next patient. The finding is subtle, or let me say the artifact. And this is something that can look like or mimic a pneumothorax. And so look at this axial image in the lung windows. There is a bullet fragment that is lodged in their right chest wall, and it's causing these linear artifacts that are going through the chest wall. And one of this looks like right here is subtle pneumothorax. And so is it pneumothorax or is it an artifact? Look at it in the coronal projection. It looks like a focus of air, but it's not. It's an artifact because of this metallic bullet fragment that is lodged in their chest wall. So be aware of this artifact. This is our next patient. They were admitted for acute pancreatitis, and we evaluated them with a MRI of the abdomen. On the top left is a axial T2 weighted image showing the pancreas and the pancreatic duct inside. There is some swelling, maybe some fat stranding, and there is this focus of T2 hyperintensity, a cystic focus, which shows some peripheral enhancement, no internal enhancement, and no restricted diffusion. And so a finding like this would be consistent with an acute necrotic collection in the appropriate clinical setting. This next patient underwent a CT of the abdomen and pelvis in multiple phases. This was a GI bleed protocol because they were passing bright red blood per rectum. So starting from the left, we have non-con arterial phase, portal venous, and delayed phase. The finding is very subtle, but it was correctly picked up by one of our trainees. In the left side of the abdomen, we find that there is a small bowel loop that shows contrast extravasation, and on the more delayed images, it dissipates or becomes less intense and larger inside the bowel loop. So this is what a small bowel bleed would look like on a multiphasic CT. Here is our next patient, and we're looking at a single coronal image from their CT of the abdomen and pelvis post-contrast. Here's the aorta, and look at the right renal artery and the left renal artery. This finding of saculations involving the renal arteries is consistent with fibromuscular dysplasia or FMD. Here is our next patient, and again we are looking at a single coronal image. They have a metallic stent in the CBD, so that tells us that there is something obstructing the CBD. Here is a hypoenhancing mass in the head of the pancreas. That's their primary pancreatic adenocarcinoma. And we see a hypodensity in the liver, which is a hepatic metastases, which are very common and seen early in patients with pancreatic adenocarcinomas. This next patient underwent a CT of the chest on the suspicion of acute pulmonary embolism. On this coronal image, we find that there are large filling defects in bilateral pulmonary artery branches. We see the same finding here on the axial image, and further down at the level of the heart, we find that the cavity size of the left ventricle is smaller than the right ventricle. Also, the septum has been pushed towards the left side and the ventricle has a D-shaped appearance. When that happens, there is right ventricular strain, and that's secondary to PE. And so we have acute PE with a right heart strain. So when there is acute pulmonary embolism that you're diagnosing on CT, always look for and comment on whether a right heart strain is present or not. Here is our next patient. They were brought to the ER on the suspicion that they swallowed a coin. And so we performed 2 views of the chest. This is the frontal view showing a focus that is not in the trachea, because we see the tracheal column is separate from that density. And on the lateral view, we find that it is posterior to the trachea in the esophagus. So this is something that has to be removed, had to be removed endoscopically. But remember that whenever you're looking for something using x-rays, always get 2 views. One view is never enough to tell where a foreign body is located. Thank you for watching.